Hello, everyone. Welcome to our webinar. My name is Jessica Porras, and I'm the Senior Manager for Education at CAQCOR. Next slide, please. I'd like to mention a few things before we begin our program. The slides are not available on our website right now, but they will be sent to you as well as the recording in the next day or so. In addition, we'll have time at the end of the program to answer your questions, so please feel free to submit your questions at any time in the questions panel on the dashboard. Next slide. This slide highlights the topics we're going to cover during our webinar. We'll start off with an overview of the CAQCOR VVP initiative, and then we'll begin our feature presentation, followed by our Q&A. I'd like to thank our speakers, Aparna Higgins, founder and CEO of Ananya Health Innovations, Inc., as well as my colleague, Erin Weber, Director of CAQCOR. Next slide. And now I'd like to turn it over to Erin Weber for our first presentation.
Thanks, Jessica, and thank you everyone for joining us today. Before Aparna gets started, I'm going to get a quick overview of some of the work CAQCOR has been doing in the value-based payment space over the last couple years. And for those less familiar with the organization, I'll give a quick overview as well. CAQCOR was founded back in the early 2000s, shortly after HIPAA, because many of the business transactions that were that had standards created through HIPAA. So if you think about eligibility, claims, EFT, remittance advice, many of those transactions were being used inconsistently across the health plans and providers. So it was very difficult for providers in particular to automate and have common expectations as they were exchanging this information with the plans. So the industry came together through CORE to develop some common business requirements or operating rules to support the standard transactions and increase the consistency and uniformity in how they are used. Our membership now includes only over 130 organizations representing 75% of the insured U.S. population, including health plans, vendors, providers, government entities, associations, et cetera. And our mission really is to drive the creation and adoption of operating rules to support standards, accelerate interoperability, and align the administrative and clinical activities across the industry. We see our role not only as convening the industry to develop the operating rule requirements through our participating organizations and subgroups, but also we believe we have a role in helping the industry implement the rules. So we have a certification program, we have quite a robust education and outreach program to put on webinars such as we're doing today, and we drive adoption and measure ROI. We were designated in 2012 as the National Operating Rule Author by the Department of Health and Human Services, and you'll see on the next slide that several of the operating rule sets developed to date have been federally mandated. So the Phase 1 and Phase 2 rules for eligibility, claim status, EFT, and ERA are now required for use under HIPAA. Additionally, we have operating rules for claims, prior authorization, and are in the process of developing operating rules for attachments as well. When CAQCOR was founded, I mentioned there was a lot of challenges in the uniformity of the information being exchanged for healthcare billing and payment purposes. A few years ago, our board recognized that their organizations were having similar challenges in the transition to value-based payments. Each value-based payment arrangement is slightly different and requires different information to be sent at different times between the various trading partners. You can see on this next slide just some data from the industry in terms of providers in particular being ready to take on risk through various value-based payment initiatives. Many senior executives believe their organizations have the capabilities and are ready to take on increased risk, but some of the major challenges that we see cited continuously are operational processes and infrastructure to support value-based payment arrangements. We spent a couple years doing some really in-depth research with industry stakeholders through primary interviews, surveying, as well as secondary research to really dig into what are the opportunity areas for the industry to streamline adoption of value-based payments, particularly from an administrative and infrastructure perspective. And out of that work, we published a report highlighting 5 key opportunity areas for the industry. And I'm not going to go into each of these in depth, but they were really focused on data quality and uniformity, uniformity around the exchange of information related to quality measures, interoperability, both technical interoperability, but also process interoperability and how and when information is exchanged. Greater consistency in patient risk stratification and transparency, and also in exchange of information related to attribution information between health plans and providers. Our goal is to move towards a common infrastructure to drive the adoption of value-based payments by streamlining the exchange of information across both clinical and administrative verticals. Over the past year, we've had an advisory group of leaders from a range of different stakeholder organizations take those 5 opportunity areas and go a level deeper into specific options for potential operating rules. And out of that work, the group identified 5 key opportunities for CAQCOR to pursue over the next couple of years. In particular, looking at patient risk identification prior to the point of service, sharing patient and provider attribution status at the time of eligibility, and the exclusion of expanded code sets on claims that support value-based payments. Those are kind of the top 3 opportunities that we are looking at moving forward through our value-based payment initiative now. We've recently held a more detailed webinar on the provider attribution work that I would encourage you to look at if you're looking for more detail on that. Additionally, there were several opportunities related to the need for additional documentation and the standard exchange of that additional documentation, such as medical records, that we are working on through some of our other initiatives related to prior authorization and attachments. The next slide gives a little more detail on the patient-provider attribution work that we are doing. CAQCOR launched a subgroup, and subgroups are groups that include representatives from all of our core participating organizations to develop potential operating rules to support the exchange of patient-provider attribution information prior to the point of service. One of the challenges we heard as we spoke with the industry was that providers often didn't know a patient was attributed to them until after care had been provided, and not necessarily aware of why the patient would be in their population, who is responsible for the patient, and who might else be involved in caring for that patient. But really the most important question is for the providers to understand, is the patient in their attributed population? So this group will be looking at the specific mechanisms as to how health plans and providers could share this information, both at the individual patient level, individual provider level, and also at the contract or group level, using existing standards and potentially emerging standards as well, supported by operating rules. This work, as I mentioned, launched just last week, and we anticipate the subgroup will meet over the next 6 months to develop potential operating rules, which will then go through our formal rule approval processes. I'd encourage anyone on the call, particularly those of you that have expertise in the area of provider and patient attribution, to consider joining CAQCOR and engaging with the value-based payment subgroup. We really need experts both in this field and those familiar with the HIPAA transactions. Multiple people from the same organizations can join. We also have several resources available, including a new online interactive module to learn more about our opportunity areas in VBP. I'd also encourage you to go to our website and take a look at the report we put out a little while ago. With that, I hope you have a good background on our focus within value-based payments, and I'm going to turn it back to Jessica for a polling question.
Thank you, Erin. So given what Erin just shared regarding the VBP subgroup work, we'd like to know whether our audience, whether you're interested in this work. So let's go ahead and start the poll. And if you click unsure, we may follow up with you to provide a little bit more information. And obviously, those of you who click yes, we will follow up with you so you can join us on this journey. So let's give this a few more seconds. And I won't share this information with the audience, but I'm happy to see that a lot of you are interested or curious in our work. So thank you so much. With that, we're going to move on to the next presentation. I'd like to introduce Aparna Higgins, who's the founder and CEO of Ananya Health Innovations, Inc. She's also a policy fellow at the Duke Margolis Center for Health Policy. At Ananya Health, Aparna is currently focused on leading the development of analytics-driven solutions and providing strategic advisory service in the design and implementation of DBP models. At Duke Margolis, Aparna is engaged in policy research on the next generation of performance measurement and value-based payment for medical technology. Aparna is a recognized leader and a strategic thinker in payment and delivery system reform, quality measure, as well as healthcare analytics, and has experience in both public and private sector healthcare programs. And with that, I'd like to welcome Aparna. We are so happy to have you here with us today.
Thank you, Jessica, and thank you all for the opportunity to present on a really important topic. Next slide, please. So before I actually talk to all of you or share with you information on the APM roadmap, I wanted to give you some background about the Healthcare Payment Learning and Action Network, or the LAN as we fondly call it. So the LAN was really launched by HHS in 2015, and the purpose of this group, which is really a multi-stakeholder collaborative, is to help advance the work being done both in public and private sectors to increase the adoption of alternative payment models or value-based payment models. And it's really a multi-stakeholder, collaborative of payers, providers, employers, consumer groups, and so forth. And it's focused on shifting away from the current fee-for-service model to value-based payment or alternative payment models. Of course, ultimately, the goal is to get to, better care, better health, and smarter spending. Next slide, please. So the first iteration of the LAN, which was launched in 2015, as I said, was co-chaired by Mark McClellan and Mark Smith, and you can see their affiliations on the screen. During this first iteration, the LAN also had a guiding committee that oversaw the work of the LAN, and it was really engaged in a lot of foundational work to advance APMs. And I think that since 2015, the LAN has really empowered both the public and private sectors, with a variety of products, including, having a common framework for classifying alternative payment models, publishing sort of foundational white papers on how to think about performance measurement or how do you design episode of care models, as well as the LAN has also been engaged in measuring the progress of, adoption of APMs nationwide. And that's a report that they publish annually, and this year's measurement results will be out soon, actually this Thursday. And the LAN has also hosted annual summits, and I'll talk about that towards the end of the presentation. And the LAN is really now moving into its next phase. We call it LAN 2.0. And in this next phase, it really remains committed to accelerating the adoption of alternative payment models with a greater emphasis on the adoption of shared accountability models, i.e. two-sided risk models that include nominal risk. And the LAN really views these models as important to advancing, both, reducing costs, improving quality, and also improving health equity. So the LAN 2.0 recently launched a CEO forum along with a care transformation forum, really comprised of committed executives and clinical leaders. And these leaders are charged with identifying important topics that need to be addressed, that can help accelerate adoption and implementation of APMs through the formation of work groups and so forth. So stay tuned, more to come. And then the LAN is also will be announcing a new set of goals nationally for alternative payment model adoption to support its focus on shared accountability models at the LAN Summit. It will be held here in DC this Thursday. And I'll share information about that towards the end of the presentation. But today what I'm going to do is talk to you about the alternative payment model roadmap, which was the capstone product of the LAN. Next slide. So what is the roadmap? So the guiding committee, as I mentioned, the LAN guiding committee really saw a critical need for having a roadmap that could be used primarily by payers, but payers working in collaboration with providers, employers, and consumers to design and implement successful, alternative payment models. So models that would drive high performance, high quality, low cost improvements in health equity. And the roadmap really aims to facilitate the adoption of these successful models by diffusing information on key characteristics of models, as well as what are, the promising practices that are drawn from various regional experiences across the country and from other innovators in the field. So we have now, I think, about a decade's worth of experience designing and implementing APMs. And so the goal with the roadmap was to really learn from innovation that was occurring in the field, being able to distill the best or promising practices, and then, sharing that more broadly to help accelerate the adoption and design of alternative payment models. Next slide. So as I mentioned previously, the LAN has released a whole set of products that are designed to help various stakeholders move the needle on APM adoption. So what you see on this slide is just a sprinkling of some of those products, and you can go to the website to actually download these various products. And as I mentioned previously, a lot of the work prior to the roadmap was really foundational, sort of thinking about principles and so forth. And then the roadmap really was focused on learning from existing implementation experience and being able to share those best practices. Next slide. So as I mentioned, the goal of for the roadmap was to really accelerate the adoption of successful APMs by sharing best practice information. There was a very structured process in terms of how those best or promising practices were gathered and analyzed and then distilled into the roadmap itself. So we wanted to make sure that whatever promising practices we were identifying were valid. And therefore, initially, the roadmap really started by conducting a set of interviews with representatives of different stakeholder groups, people and as well as experts in the field, people who had experience designing and implementing models. First, really understand what are success criteria that are currently being used to assess whether an APM has been successful or not. And so based on those set of interviews, the roadmap is really predicated on 5 types of criteria that were used to determine if whether the APMs that were included in the development of the roadmap were actually successful or not. And these wouldn't be surprising to any of you on the call. So the first is cost. Obviously, alternative payment models or value-based payment models should reduce cost of care for payers, cost of insurance coverage for purchasers, and then out-of-pocket costs for patients. Quality, obviously, is really important. Was another criterion in terms of looking at APMs that improve quality of care, as well as patient experience. So it's not just about improvements in clinical quality, but it's also about improvements in patient experience of care. And then the last, the fourth criterion was really around provider experience. The goal here being that APM should really help reduce, administrative burden. And obviously, CAQH is very engaged in that in terms of reducing burden for providers, but also being able to preserve clinical autonomy for providers. And then the last criterion was really looking for APMs that help improve health equity by, reducing health disparities where they exist. I think initially, based on these success criteria, we tried to define very specific metrics for each of these criteria and tried to collect standardized data from the payers who participated or submitted their data for the purpose of developing the roadmap. But very quickly, we ran into challenges. A lot of it had to do with variability in measurement, as many of you probably know. And so I think we modified our approach a little bit, still used those criteria, but then had to, couldn't have it be as standardized as we had originally envisioned. And then starting with the success criteria, then we had a whole process for how we actually collected data from the various, plans and providers who participated in the development of the roadmap, analyzed it, and then, led to the publication of the roadmap itself. Next slide, please. So I'm going to talk about this in too much detail. This is just to give you a sense for the very sort of robust process that we use for developing the promising practices that are described in the roadmap itself. So it was a combination of a variety of work groups that we constituted explicitly for this purpose. On the left-hand side, you can see the LAN Guiding Committee, obviously, that provided overall strategic guidance and ongoing oversight, along with a specific work group called the Roadmap Work Group that was constituted for this particular project, that also worked in conjunction with the Guiding Committee to provide oversight and guidance throughout the development of the roadmap. And then an implementation group that was really focused on identifying the metrics of success that I talked about a couple of minutes ago. And then in conjunction with all of this, and in addition to expert interviews, we also did a targeted literature review, stakeholder interviews to help, further refine the types of questions we were asking, and used a structured interview guide to actually collect the data from the various participants in this project, analyzed it, synthesized it, and then, led to the development of the roadmap itself. Next slide. Before I talk about the actual findings from the roadmap work, I wanted to talk a little bit about scope. I'm sure many of you are familiar with the LAN alternative payment model framework. The framework was one of the foundational products that came out of the LAN. It was really a way to categorize the different payment models that were being designed and implemented. So it gives you a structured way of categorizing payments that are alternatives to fee-for-service. And what you see on this slide is a graphic of the actual framework itself. So on the left-hand side, it starts with the Category 1 payments, which are really fee-for-service, moving on to Category 2, which are still mostly fee-for-service, but with some link to quality and value. So it could be things like, fee-for-service plus pay-for-performance or pay-for-reporting, fee-for-service plus care management fees, for example, for care coordination and so forth. And then you have categories 3 with a bunch of subcategories underneath that, that includes alternative payment models that have either shared savings, as well as, shared savings with some level of downside risk. And then all the way to the right-hand side, which are really what we call Category 4 payments, which are population-based payments. So these are prospective payments. They could be either condition-specific or they could be comprehensive, global budgets, as we call them these days. And the reason I wanted to sort of provide this framework as a level set is that, I think the interest here is to really move the adoption of APMs into categories 3 and 4. And so in order to facilitate that, the scope of this roadmap was really focused on examining the best practices in category 3 and 4 models that have been designed and implemented to date. Next slide. So more on the scope. I mentioned that we conducted in-depth interviews with both payers and providers. So what you see on this slide is the number of organizations that were included in the development of the roadmap from whom we collected data. So there were 9 regional and national payers, including Medicare fee-for-service. And even though there are only 9, there were several large payers. So together, the participating payers represented approximately 135 million covered lives. We also spoke with a number of provider organizations, 13 provider organizations in total. And also, the roadmap is reflective of different types of APMs. So we included organizations that are designed and implemented ACOs or patient-centered medical homes, but we also interviewed organizations that were implementing episode-based models. And then even with respect to the providers, there was quite a variety in terms of, the types of providers that were included. You had providers in both ACOs as well as participating in clinical episodes, but also included in terms of size, larger practices, but also, smaller practices. So we wanted to make sure, even though this wasn't a formal evaluation, that we had, representation in terms of the provider mix, both in terms of the types of models that they were participating, but also in terms of the size of the provider organization, because that obviously affects their approach to, entering into these new models. And then a variety of lines of business as well, as you can see on the slide. Next slide. So next slide, please. So now we're going to really jump into what are the findings of the roadmap, and I'm going to do a little bit of a deeper dive into that. So after doing this in-depth data collection, which was through both structured written data collection tools, but also in-depth telephonic interviews, we analyzed the data, and the findings really fell into sort of three broad buckets, as you can see on the slide. There were a set of best practices or promising practices around the design of APMs, and again, under that there's a bunch of sub-themes as it pertains to the payment structure, benchmarking, quality measurement, so on and so forth. And I'll talk about a little bit more detail each of these in just a minute. The second major category is around payer-provider collaboration. I think this is an area that I'm sure all of you have heard about a lot and is really critical to the success, both in terms of the design, but also ongoing implementation, ultimately success of APMs. And then the third leg of the stool, obviously really important, which is, and this is the reason why we're in this and doing this, is to ensure patient-centered care. And again, there's this, several sub-themes under that. So what I'm going to do for the rest of the presentation is actually kind of provide some additional detail and color in each of these areas. Next slide, please. So there's a lot on this slide, and I'm obviously not going to speak to every single bullet, and I'll share towards the end of the presentation how you can actually access the roadmap. But I wanted to sort of highlight a few areas that I think, are important in the design of APMs. So when we interviewed the payers who participated in this roadmap development, I think they were really using a variety of practices to succeed in the design of these APMs. And it really depended also on, what types of providers they were working with, and the interest in being sort of flexible in terms of how they design and implement, the APMs for their provider organizations. With respect to the payment structure and financial risk, it's really important that for the payers to align the structure with the provider capabilities. So what they're really looking for is how ready are the providers to enter into these new models. And readiness is really assessed in sort of a variety of criteria, including things like, do they have the right data infrastructure? Have they been in some kind of other, for the private payers, they look to see if providers have been in some other kind of CMS model, for example. So there's a criteria that payers are using to assess readiness and then tailor the design of the model accordingly. And then, in terms of the population-based models, payers also establish sort of utilization-based shared savings models. So if they found that providers were not quite ready to take on financial risk, some of the savings were not based so much on total cost of care, for example, initially at least, but could be based more on, utilization. And then relative to designing of the episode-based models, payers were working very closely with providers, both in terms of the definition of the episodes, for example, in terms of when does it start, when does it end, what services are included, and so on and so forth. And then it was really important as we spoke with the with the payers, that we learned that it's not just about how you structure the payments, but ensuring that these payments are given to the providers in a timely manner. And that also that some of these payments that the payers are giving to the providers are really tied to sound investments in improving care. So for example, if payers, if the contract includes a care management fee, for example, there are certain requirements that payers impose on providers, for that care management fee, and could include things like ensuring 24/7 sort of, access, ensuring that the providers are monitoring, for example, ED use and hospital discharge and doing appropriate care coordination, that the providers are actually, some cases, hiring care coordinators. So there's a certain set of requirements that the payers are looking to, for the providers to include, that the care management fees then become contingent on meeting those criteria. Benchmarking utilization, obviously an important area, because that helps determine whether providers are going to be earning incentives or not. And here again, a variety of different approaches to establishing benchmarks in both the population-based models as well as episode-based models. I think typically they tend to be historical benchmarks, and those are used, where you look at a provider's experience historically and then establish benchmarks based on providers' historical spending, for example. And that, payers found to drive year-over-year improvements. But then, once, the efficiencies in terms of using historical benchmarks can only go so far. So some models, what we found is that there's a combination of using both historical benchmarks for a provider, but then it's combined with a regional benchmark to allow for, providers the ability to earn shared savings. And then, one of the things that it was really critical that came through was that payers are really trying to minimize, transfer of insurance risk to providers. And so that's where, again, utilization indices can be helpful. What they're trying to do is to transfer performance or clinical risk, but not really expose providers to insurance risk. With respect to quality measurement, I guess not surprisingly, we found that most of the measures that are being used are HEDIS, especially in the population-based models. Episode models slightly different. Standard metrics in episode models tend to be things like readmissions or ED visits, but also, some condition-specific or episodic-specific measures, things like, complications. For example, if you're looking at a surgical episode, return to work and things of that nature. And then lastly, I would say that, multi-payer alignment, really critical, came up, multiple times, both in payer interviews, but also, provider interviews. And here again, I think what's really important for multi-payer alignment is strong leadership from state agencies and as well as dominant payers within the market. Next slide. So as I mentioned, we interviewed both payers and providers, and therefore, we heard a lot of provider perspectives around APM design. And specifically, we heard quite a bit from providers in terms of, how to prepare or get ready for participating in, downside risk models. And providers mentioned a number of things that were important for an organization to succeed in downside risk models. So the first thing is really aligning financial incentives for individual clinicians. So a lot of times with these alternative payment model contracts, the contract is really between the payer and the provider organization. Up until recently, the individual clinicians who are part of that provider organization in many cases didn't even know that their organization was in an alternative payment model. But we're starting to see that, change. So in what was emphasized as we, when we were doing these interviews was that it was really important to align the financial incentives for those individual clinicians within the provider organization with the contract that the provider organization has with the payer. This could be things like, for example, tying individual clinician in a reimbursement to the level of shared savings that the organization might achieve. So that was, sort of critical. The second piece that we heard is that it's important for organizations that are thinking about moving into downside risk models to really demonstrate success in upside-only models. So these would be models that only have shared savings in them, because those, in sort of participating in these upside-only models allows providers to get experience being in a model that's an alternative to fee-for-service, allows them to build the infrastructure that's needed so that they can actually be successful when they decide to move into these downside models. The importance of data and information came through in all of our interviews. It was an area of great emphasis, both among payers and providers. And, especially for providers moving into downside risk models, having adequate and timely access to payer data was emphasized by providers, especially the raw claims data, but also the attribution data. And, Erin talked about that earlier today in terms of the work that CAQH is undertaking. So if you are, and especially if you're in a prospective model with, let's say, full risk, it's really important to know who you're accountable for, and having access to timely information on the list of patients for whom you're accountable for is absolutely critical. And that was something that came up repeatedly across our provider interviews. And then also thinking about longer term strategies, which would be things like, how do you manage utilization? How do you shift utilization from higher cost settings, for example, like hospitals, to lower cost settings, like ambulatory care facilities, for example, and also thinking about referral patterns and so forth if you're a PCB. A couple of areas that, also the providers mentioned and talked about quite a bit is around quality measurement, but also quality improvement. So, all of these providers in these contracts have to meet quality targets. And in order to be able to do that, they need to really think about how they manage their practice internally. And so the providers are using a variety of ways to do that, including things like, setting quality improvement goals that tie back to the, contractual performance requirements, for example, and then really trying to work upstream in terms of managing your patient population, including addressing things like social determinants of health and preventive care. So it's not just about seeing the patients who walk in the door, but being able to identify patients who don't walk in the door, making phone calls, getting them in for wellness visits and things of that nature. Really redesigning the workflows internally, was really critical to success. This included things like how do you seamlessly, integrate EHR with claims data? How do you actually use data at the point of care? How do you, make that information actionable and available to clinicians, and providing them with guidelines, for example, at the point of care? And really, thinking about how to work in a team-based environment. Providers talked a lot about establishing cross-functional analytic teams, for example, that allow them to integrate the data, aggregate the data across multiple payers, combine claims and clinical data and make it available, but also thinking about how do you practice in a team-based way. It's no longer only about the physician, but also about the physician extenders and what their role is, and what role they can play in terms of managing patient populations. I would say that there were some bugaboos from the provider standpoint. Again, nothing new. I'm sure you've all heard of this previously. As it pertains to, since providers have multiple contracts with multiple payers, they all talked a lot about lack of alignment, both on the actual measures that were chosen, but also the measure specifications, although there's work underway to address that issue. There's a lot of also, barriers around lack of alignment relative to required documentation across the various, contracts that providers had with payers. Relative to the kinds of care plans, for example, transferring care plans, to each payer, knowing when patients change insurance, a lot of these things, different requirements for prior authorization, for example. So a lot of these things sort of, added to the administrative burden and made it more difficult for providers. Also, lack of alignment on data sharing in terms of, the content that's included in the reports that come from payers, the types of data that are shared, the interval with which data are shared. And then with respect to episode models, again, there was variability in terms of, episode definitions. For example, if a provider had more than one, contract for, let's say, a knee surgery, how that knee surgery episode is defined could vary across payers. And again, that was a, source of frustration for providers. So again, more work to be done on the alignment, but I think that's a sort of a key finding that emerged from the interviews. Next slide. So I want to talk a little bit about the payer-provider collaboration that I emphasized. So some of these things I've already mentioned previously, but wanted to highlight a few things that were important. So in terms of, from the payer standpoint, they're really looking to collaborate with the provider on the APM design, in the design phase as well as in the, implementation phase, and they use a variety of approaches to do that. A number of the payers we spoke with when they were thinking about designing and implementing an APM really kind of started with small cohorts of their provider network. So they didn't go network-wide initially, but really started with small cohorts of their advanced providers to kind of, who would serve as a test bed for the design and implementation of these models. So they worked pretty closely with these provider groups in terms of designing and implementing these models, and then iterated based on that experience and that learning to then, deploy these models more widely across their network. Payers also established these joint operating committees, and they found these to be really valuable. These are meetings where the payers and providers get together on a regular basis. They review performance data. They identify, they help the providers identify specific process improvement opportunities or learning and diffusion systems that use, sort of multifunctional platforms for communicating with providers, and also different ways of disseminating programmatic information. I talked quite a bit about the data and sharing and analytics. Obviously, that's a really critical part of success in these new models. And I think what's important, again, is the flexibility. Payers are really trying to tailor the types of data and information that they share with providers in these new contracts based on the provider readiness. So, for example, with large integrated delivery systems, it could be that payers are sharing raw claims data because these systems have the ability to ingest that data, integrated with clinical data from their EHRs, and create this integrated data repository and run analytics off of it. Smaller providers may not necessarily have that kind of capability. So typically, the types of data and information that's shared is more in the terms of, quote unquote, canned reports, things like gaps in care and so forth, that the smaller providers can actually use in managing their patient population. And then a lot of emphasis on leadership and organizational culture. Payers really consider that to be a key component of provider organizations' capabilities, and then use, sort of several criteria to assess an organizational leadership. So, for example, does the organization have, an incentive structure internally that matches up with the incentive structure at the organizational level? Is the organization investing shared savings in care delivery improvement and so forth? So these were all, criteria that payers were looking to in terms of assessing organizational leadership and culture. Next slide. So what do providers think about payer-provider, collaboration? So again, here, there's from the providers, we heard that there's sort of a series of steps that they undertake to prepare to participate in APMs. So obviously, really key, as I mentioned several times already, building the right set of data capabilities, particularly in the smaller practices. This included identifying the data needed for quality monitoring, establishing and tracking performance goals, for example. Another sort of key way, infrastructure piece is, implementing changes in staffing and, defining sort of different roles and responsibilities within these practices. Especially those in smaller practices, they discussed extensive staffing changes in the population-based models. These included things like, hiring a care coordinator, even if it's not full-time, maybe part-time, working with social workers, and then figuring out how to engage patients and how to involve different office staff in, better patient engagement. Delegating greater responsibility to care coordination staff. So again, it's not always about the physician. And then providers also really emphasize the, collaboration with external organizations, both in terms of, acute care settings, but also, how they manage specialist referrals and so forth. And some of the providers we spoke with that actually established patient advisory councils, and these were really groups of patients who they were seeing in their practice, but helped these practices kind of think about patient engagement and how to deliver care so that, it resulted in better patient experience. For episode-based models, I think what the providers emphasize the most is, shifting to lower cost of care sites, so lower cost centers. So moving away from using the hospital purely for surgery, for example, to ambulatory surgical centers. Following clinical protocols was another key area for ensuring both quality and cost in episode-based models. I've talked quite a bit about the data analytics, so I won't sort of repeat a lot of what I've said. Again, really important to have both clinical data, but as well as, claims data. With the smaller practices, a lot of times they talked about the challenges of configuring their EHRs, but had to sometimes hire outside consultants to help them develop reports that could be generated off their EHRs. But they also saw a lot of value in the payer reports that came to them that were, pre-formatted and analyzed, things that highlighted gaps in care, reports that flagged patients with high-risk clinical conditions. The providers found that to be really useful in terms of managing the patients. Some of the larger provider organizations, even though they had the capability to ingest payer claims data, they did express some frustration in not being able to get timely access to that kind of data. Care coordination was, again, another important area where having promising practice and implementing best practices was important for success. And sort of there are various components to care coordination from the provider standpoint. Some of it has to do with patient outreach, engagement, and education. Again, this is, like I mentioned, not just, taking care of the patients that walk in the door that are showing symptoms, but actually being able to do outreach to patients who are on your panel who haven't yet come in for a visit, for example. And then when they do come in, really engaging with them in educational efforts, sharing information on wellness, making sure they're getting their preventive services, those kinds of things. And the providers really use data in terms of helping with their care coordination and setting care management goals for their patients at different levels of risk and being able to sort of monitor that. That was a critical part of the care coordination. And then, there's a lot of emphasis on integrating primary care and behavioral health. Although, for providers who were in rural areas, this was, obviously quite challenging to find, supply of specialists, behavioral health specialists. Sometimes some of them were using telehealth, for example. And then with respect to other, types of specialists, they, did talk about some of their referral strategies, wanting to make sure that they were referring their patients to specialists who are willing to work with the primary care docs and being able to, work collaboratively and ensuring that the PCPs can be successful in these new contracts. And then, again, a big area of emphasis here for providers was leadership and culture. They really emphasize team-based approaches to population health and clinical episode models. I've talked about that quite a bit. But all of them really, I think, underscored the need for this buy-in from senior leadership, that it really had to start at the top, and that belief and that value-based care is the way to go, and that it's important to move the organization in the direction of value-based care was something that was critical to organizational success. And providers are using a combination of financial and non-financial incentives to engage clinicians. I talked about some of the financial incentives, but there were a number of non-financial incentives that are also being used, including things like, sharing performance reports internally, and in some cases even publicly, where call it public praise or public shaming, if you will, but really being able to use both financial and non-financial incentives. Next slide. Really quickly here, I think the payer practices on ensuring person-centered care, are pretty typical for payers. I don't think there were a whole lot of differences in terms of how payers engage with their members in the context of value-based payment versus, so traditionally how they do direct, member engagement. They both work directly with the patients and their members in terms of educating them and, entering into care compacts with patients, for example, but they also work with the providers and helping the providers in terms of ensuring that they're working in multidisciplinary teams to deliver patient-centered care. Benefit design is an area that I think is ongoing work, and this didn't come up a lot, Payers are beginning to develop ACO products that better align sort of the insurance benefits with the provider incentives in APMs. Also using things like narrow or tiered networks, selection of, primary care providers, and then also incentives to members directly for choosing high-value providers. But I think this is an, evolving area. Next slide. Provider, obviously, delivering person-centered care is really important to providers, and they do it in a variety of ways, some of which I've touched upon. In terms of engaging patients, I talked about doing outreach and bringing patients into the office, but providers also do this through a variety of ways, including, use of patient portals and smartphone apps, but also find ways to engage patients through their communities, for example, in schools or local health departments and so forth. So any way that they can try to engage the patients and bring them in and ensure that they're following the care plan and so forth is used by providers. They also used a lot of targeted communication, especially for patients with chronic conditions or for patients who are going through surgery, for example, ensuring that they're following their care plan. They know what number to call if there's an emergency. It may not be a true life-threatening emergency, and therefore having access to after-hours care was important. I talked about the patient advisory councils already, as well as trying to increase access through telemedicine. Health equity is obviously a huge area. I think that a number of the providers we spoke with talked about doing social needs assessment, using questionnaires at the time the patients come into the office, as well as having informal conversations to better understand their socioeconomic needs, and then finding ways to connect them to community resources. So it's not necessarily that the providers are giving them the meeting their non-medical needs, but being able to know, for example, where to refer patients for housing or transportation, or to address their food insecurity, for example. So those were all strategies that were, used by providers. Next slide. So I want to talk about briefly the path forward. I think there were a number of areas that obviously, we tried to address in the roadmap, but I think more work needs to be done. First is the area of quality measurement. Again, here the importance is to shift away from clinical process measures and move into outcomes-oriented measures. I think focusing more on patient engagement in the design of the APMs themselves. We didn't see a lot of that when we interviewed the payers and the providers, and so getting patient involvement in the design of these alternative payment models would be, important. Multi-payer alignment, obviously a key issue that's come up repeatedly in various provider interviews and other forums. And then also thinking about how do we sort of design, benefits in the future. Next slide. So where can you find additional information? So the LAN website actually, and you have the URL at the bottom of the screen there. There's a full PDF report that you can download, but what I would recommend is really the interactive tool that you can use. So you go to the website, and then there's a bunch of icons you can click on. You can jump around different parts of the report. There's a lot more detail than what I went through on this call. I tried to give you a flavor of the kinds of information that's available. And then the nice thing about the interactive tool is you can jump around. You don't actually have to, go page by page. So this is where you can access the actual full roadmap itself. And then next slide. I just wanted to put in plug for the LAN Summit, which is actually this Thursday. I think registration is still open, and I think they're live streaming the plenary session. So please register. There's a lot of great sessions and speakers that are going to be sharing their experience in designing and implementing alternative payment models. Thank you. I'll turn it back to you, Jessica.
Thank you, Aparna. I really appreciated your presentation. In particular, I like seeing the going back and forth between the payer and the provider perspective. I found it really interesting. There was a lot of alignment, but a couple of things that were just a little bit of a difference in lens. So I found it very fascinating. We do have time for questions. I'm going to let the audience, if you have any questions, please feel free to submit them now. I do have a question for you, Aparna. I know that a lot of times in our webinars, we get a lot of, kind of solo practitioners that are really new to the topic area and they're trying to learn. And the roadmap has an incredible amount of information, but I wonder if you could give some advice to these providers that are trying to learn, like how do they go about using this roadmap to kind of, help them learn how their industry is changing, right?
Right. So I think there's sort of different parts of the roadmap that I think would be really helpful to, smaller practices or solo practices that are looking to move into these new models. There is a particular section in there about, that's based on provider perspectives and what providers who are in these models think that new entrants would need to do and sorts of things that they would need to think about as they are entering into these contracts. Things like, what kind of data capabilities do I have right now? What are, for example, some of the contractual terms that I might need to think about relative to moving into these new contracts? What would be the terms of how would the payment be structured? What would I be on the hook for relative to performance? How would I find out, how patients are attributed to me? Who would I be accountable for? And how can I get information on those patients in a timely manner that would allow me to manage, manage that patient population? As well as thinking about, are there, if you're in a purely fee-for-service contract right now and you're looking to move into these value-based models, I showed the APM framework. So typically the glide path has been not jumping from fee-for-service all the way to global budgets. Obviously, that's a huge leap, but really thinking about, can I move from fee-for-service into a model where there might be fee-for-service plus some, sort of care management fee or PMPM that would allow a provider to build the infrastructure needed that would then, set them up for success as they move into shared savings or shared risk. I think those are the things I would point out, but there are particular sections in the report that speak to this in greater detail. And I think that's where the interactive version of the roadmap could be really helpful.
Thank you, Aparna. That's really helpful. And we, in fact, just got a question from someone who, I'm going to paraphrase their question, but they were mainly asking, how do we manage all of this change that's happening so quickly? And so I think what you just said makes sense as a way to get started, right?
Yep, that's right. That's right. I mean, you can't, it's taking small steps, and I think it's building on sort of initial successes, and then, going from there.
Great. So the next question, the audience member wants a little bit more information about what you touched upon in your presentation regarding the alignment between like behavioral and physical health care. If you can, any lessons learned from that?
Sure. So I think the integration, so it's really around integration of behavioral health and physical health. So I think the providers that we spoke with, were trying to integrate the two, and there were different ways in which they were doing that. Some of this is obviously predicated upon the availability of behavioral health specialists in the areas that they were practicing. So a lot of times what the providers were, doing were identifying behavioral health specialists and trying to work with them in terms of addressing the behavioral health needs. So this could be, clinical social worker, for example, or it could be a physician. And it might be that they're referring their patients out to those behavioral health specialists, but in some cases they were also having those clinical social worker, for example, come to their practice a few times a month or some frequency, let's say, in order to ensure that they were addressing the behavioral health needs. So it's really a combination of approaches. It depends upon the size of the practice. Again, it depends upon the region where they're practicing. For example, if you're in a really rural area, you won't have access, you may not have ready access to behavioral health, and that's where telemedicine, for example, was a strategy that was being used. So it depends upon, your particular set of circumstances, but those were some of the ways in which providers were trying to integrate behavioral health with, physical health.
Great. And then we have time for one more question. And the question is, when should we expect payments to begin reflecting the value-based contracts? When should we be planning for new for these new contracts? Can you?
Well, there's a lot of implementation going on currently. I think I mentioned that we've been sort of implementing these new models for about a decade. Nationally, we have a little over 30%, and we'll know the new numbers this Thursday, of payments nationally that are in these alternative payment models. And so I anticipate that will accelerate. Obviously, CMS is announcing new models, and a lot of the private payers are moving in this direction as well. So I would say the journey in this is going to continue. I don't think, we're going to be staying in fee-for-service. The LAN will be announcing new goals for moving into alternative payment models on Thursday as well. So stay tuned for that. And I just expect that this trend will continue.
Great. Well, thank you so much, Aparna. Your presentation and then also your engagement during Q&A was very helpful. I'm just going to, end the webinar with a couple more slides. This slide shows the benefits of engaging with us here at CAQCOR. If you'd like more information, please go to our website or email us. The next slide has some information about our free resources available on our website. The next slide has information about our upcoming webinars. Please register and join us for 2 webinars in November. And then finally, I just want to thank all of you for your time and hope you all have a great afternoon.
Thank you.